This is Hadley.
Yes.
Can you say hi?
Hi.
There's Walter. There's Rachel.
Hello.
All right. So I was going to ask your questions, okay?
Okay.
So I'm on the call. Okay. All right. You want to sit down? You can go back up. Okay. Sorry, you guys. Okay. So I kind of started talking about this in the introduction. We just found out in January. And, with the 17 degree, the 12 and the 17 degree, I was like shocked. And the person who was like, yep, she has scoliosis. And I go, well, what do I do? And she's like, well, we'll get another x-ray in July and we'll see. And I'm like, see what? And she's like, well, we don't brace until 25 degrees. So we'll just wait until that happens. And I was just like floored. Spent several days in shock, if not weeks. And I have an awesome aunt who was like, what? I will start doing research on your behalf. So she started looking at things, sending me information. And I just kind of had this dreaded feeling that I was like, I know there's a problem, and I wasn't given anything to do to try to stop that from happening, like the 25 degree mark. So with that said, my questions, we're still very early on in this process. But it's why does the general community, like general medical community, just encourage wait and see until 25 degrees. And then at 25 degrees, it's suddenly like, oh my gosh, you need a brace and you have to wear it like all day. So why is there not an in-between that's being offered? I had to seek that out and find it for myself. That was not offered to me through, where we're at, but they've gone along with everything. I appreciate that so much whenever I've needed the prescriptions and such. But why just in general do we just wait till 25 degrees? My kind of comparison, my metaphor is we wouldn't tell someone who had cancer that we found out at stage 1 that we'll wait till stage 3 to do something. So why are we doing that with scoliosis?
When you talk about like in between, that's talking about like the therapy, but also are you asking about like part-time bracing too?
Right. Yes, because we're waiting to get a second data point on our x-ray, since we've only had one and we didn't feel like it was super accurate. So we're trying to just kind of assess what's going on and if the Schroth therapy is helping the curve. But yeah, why wasn't anybody like, well, you can do this and you can do this and we can help you find this, or have you considered part-time bracing? Like that's all kind of, I had to dig for that and come to Rachel and like even know that was even an option.
Yes, this is a question that could kind of go to anybody. So if any of the doctors, orthotists, therapists feel like they want to tackle it.
Can I weigh in a little bit? Ashley's mom asks the big question, which is, what's the science behind our advice, right? So whether we're treating cancer or pneumonia or a cardiac condition, what we owe to the patient and the family is the best evidence-based advice, right? Because if we're shooting from the hip and it's just our instinct and intuition, then we're going to be inconsistent. So we owe it to our patients to not go with our gut, but and this applies to almost every aspect of healthcare. So there's a long history of treating scoliosis. It's hundreds of years. And there's a lot of things that have been jettisoned over the years. And in my long career now, I've seen a steady support for bracing. Now, a lot of the old literature really looked backwards, and there wasn't a lot of really top-notch papers and studies that went prospective. And that changed probably in the last generation and a half. And there was a really important study that was published now about 11, 12 years ago, New England Journal, where we braced in one group and we observed the other group. And we had monitors in, and Luke was actually front and center as a supervising, quality and assessor in the background. I was at one of the centers that provided patients. So it got published, and basically it did turn the whole meter and advance the ball, to mix my metaphors here a little bit. So basically, in a prospective study, it proved that bracing worked. Now, the interesting thing about that study was that initially it started at 25 degrees, because that's been the Cobb angle that's really set in stone. That's been multi-generational. 25 degrees is when we we advise folks to consider bracing. And that's just a number that really historically, we used. One of the reasons for that is that if you treat a 12-degree or 15 or 17-degree curve, there will be many of those curves in which natural history will not progress those curves. So in other words, I think what the question you have is, well, what's the downside of treating all curves? Well, the downside is that you will probably overtreat some curves. Okay. And treatment is not, depending on the condition, depending on what health problem you're treating, is not always benign, right? I think we all know that putting a child or an adolescent in a brace, it impacts their quality of life. And, and we all know about the physical and emotional aspects of this. So that's what we owe to a great degree our families and our patients, is we've got to make the correct decision and not necessarily overtreat a healthcare problem. Now, the good news on all this is that we hear our patients loud and clear. And what has evolved in probably the last 10 years or so is a receptivity to partner with our therapists and partner with our orthotists on, say, a part-time look or some other modified brace look. Now, what continues to be a challenge for us is to approve it with the best science, right? Prospective studies and monitored studies and the best study design. So that's still a challenge for us. But I can tell you that all these people on this call today are all about shared decision-making. And so you're preaching to the choir here. I mean, we're all on the side of, patient outcomes, but we're also sensitive to the impact of our treatments. So I know that's a very long-winded answer. And what is moving slowly is across the world, you are seeing that threshold for treatments lowering. What I'm challenged with in any market in which I've been working is the expertise, right? So I've been pretty lucky because I've crossed paths with Luke and Walter and my therapists, including Rachel, actually in my old job. So these are experts. These are authorities. And there's a lot of people who have not a lot of comfort at scoliosis care. Let's see what happens. I'm not sure if it'll work. They don't really have an algorithm for follow-up. They don't know how to assess a kid in a brace. So, what you have in this group is a bunch of dedicated, quite specialized people. But, in most practices, there's not really that experience and that training. So I think it does speak a little bit to seeking out people who are very comfortable with this condition. And then you're going to get a confident conversation and a shared decision making. So hang in there. There are people who treat 20-degree curves and even 15-degree curves. But that's the answer, is that historically, a lot of the societies that review the literature just said the literature is lacking on this. And so that's really kind of the pat answer to a question like that.
I mean, I just agree with Dr. Price. So thank you, Ashley, for the question. I think a lot of parents ask that. I think a lot of parents come to clinic and have that same question. And absolutely, I couldn't agree more that it boils down to not wanting to overtreat and not wanting to, go and ask a family to, help out with their wearing a brace for 18 hours a day, or even doing part-time bracing if it's not needed and not necessary. I also agree that, within the last 10 years or so, definitely the new school of thought, or people that, spend every day thinking about scoliosis, is, what, we can use other things to help us determine which kids are at higher risk of progressing. So which kids have a strong family history of scoliosis, perhaps those kids we can start earlier, or which kids, maybe they're 12, maybe their curve is 17 degrees now, but it was 10 degrees, 6 months ago. Like it's still early. We're below 25, but we've seen some progression here. Let's be even more aggressive. And I think having that open conversation with the families and letting them know that, there's a potential that we could be overtreating here. Like, what is your risk threshold? I mean, it's your kid, it's the kid, it's your kid, it's the family. What path do you want to go down? So I think more so recently offering those options is definitely how we're progressing.